So much for joining me this afternoon, Hilary. I appreciate you being here.
Thank you for having me. I appreciate being asked to be here.
Of course, of course. And before we dig in, because I'll just tell parents now, we have a lot to talk about. I'm really excited about this conversation. But we were talking a little bit beforehand, and I'd like to dig back into that painting behind you. And
Ah,
it is wicked cool. I love that.
it is cool, isn't it? I know it's.
Yeah.
I fell in love with this painting at a coffee shop in Vancouver, about 4 hours away from where I live. I was down with my daughter and a friend, going to a show at the Queen Elizabeth Theatre, and we'd gone to a coffee shop, and this guy had taken his X-rays from his different body parts and had kind of Day of the Dead painted them up. And
Love it.
his way of like kind of working with where his health was at, and we ended up, while I'm at the Queen Elizabeth Theatre in this awesome presentation, I'm negotiating purchasing with him this whole time because we're going to be leaving town after the show.
Okay.
So, what's very important about this, as well as it being dental x-rays and kind of funky and colorful and beautiful, is that it was missing a premolar. So a premolar, like these are your premolars, these are your molars.
Mm-hmm.
And this premolar was actually missing. And the guy, part of his grief with this was that he was missing that tooth. He's also really worn his teeth down. Um,
Mm.
there's probably a reason why that tooth had fractured and had to be removed. But yeah, I loved it so much, and it was just such a beautiful piece. And so he and I figured out a way for me to get it from him, purchase it, and an agreeable price. And then when I brought it back home, um, a long time I wanted to have this happen, but my daughter ended up painting back in this premolar and doing her own cool, you know, designs on it. And so, like many of the providers that you've talked to on this Airway podcast, like our focus is on growing the jaws to fit
Mm-hmm.
the teeth, right?
Right.
And so, although this person didn't not have the space for it, our goal is to keep premolars and to keep teeth in the jaws. So I just thought it was a really great metaphor too for this work. Is the like, yeah. So thank you for noticing.
I just think that is really, really cool. And I love the story. It really speaks. It
Yeah.
makes sense why it found you. The
Yeah.
art found you. There was a reason.
Yeah, totally. Yeah.
I love
Plus
that.
Harry Potter book 4 with the Vancouver Symphony. They were doing like the symphonic uh whatever it's called, like when they have the copy of how the symphony is played throughout the movie, and then
Yeah.
they that's the movie, and it was so awesome. So
Well, I
it
love
never.
those kind of things. They're fun. They're fun.
Yeah.
Okay. So now that we know about the cool painting,
Yeah.
it was important, and listeners are probably going, what are they doing? But it actually speaks to you and a lot of things we're going to talk about,
Mm,
which is another reason I just really wanted to bring it up. It was so appropriate. So let's start our conversation by talking about your personal journey into
yeah.
oral myofunctional cranial guided dental care and airway and leadership.
Yeah. Yeah.
So where did this start for you, and who inspired you to get you towards the path you're on now?
Yeah. My first exposure to this work happened. So I had practiced general dentistry for about 20 years and was leaving general practice for a couple of reasons. One is I had been in a car accident. I had a lot of sort of chronic pain associated with the postures of dentistry. It was the right timing in terms of practice, practice timing to transition to work that I had been doing at BC Cancer. So I've been working as a dentist at BC Cancer as a consultant for 25 years. And I thought, I'm going to go there, expand the scope of care that we provide, and just really kind of settle into less intense of a business like practice life and
Okay.
focus on care at BC Cancer. And so I had already registered. A lot of my career has been spent with the Coase Center in Seattle, which is an incredible place for postgraduate
Mm-hmm.
learning. You've interviewed previous Coase graduates and mentors and CIs.
Mm-hmm.
That's been a really big home for me, dentally, personally, professionally, and I was signed up for Dr. Doug Thompson in 2018, had started um, teaching the first wellness week, which was integrative oral medicine. And it was a pretty mind-blowing week. It was 5 days. They did we were doing continuous like glucose monitoring throughout the day. We were learning about like symptoms and signs in the body of systemic health that are connected to oral health. Many of those have become normalized now over the past 6 years. So it wouldn't be a surprise for people to understand that inflammation in the mouth indicates inflammation in the body. We know the connection
Mhm.
of our microbiome in the mouth and our nasal passages to our digestive tract. So those things were kind of new in 2018, and it was kind of
Right.
revolutionary. Now they've become almost normal. And so, but what was mind blowing at the time was how much information he was giving to us and how beautifully he taught. And on the last day of 5 days, and I was kind of thinking, like, I was looking at how I'd bring this into the cancer agency. Like, would I be looking at microbiome and restoration of microbiome in patients who've gone through a lot of cancer care? Would I be
Mhm.
I wasn't totally sure, and I started really thinking about the impact of dry mouth from cancer therapies, and so my focus was kind of like in that. And then
Okay.
on the last day of the course, the fifth day, your mind's almost full, and this part comes in about oral myofunctional therapy. And there's a condition in dentistry called a class 2 where the upper jaw is further ahead of the bottom jaw.
Mhm.
And well, I could even show you a model because I have it right here, my daughter. So the upper jaw is ahead of the bottom jaw.
Okay.
And what we learn in dentistry is when you see this, you're going to need ortho, right? Like small
Right.
jaw, wait till all the baby teeth fall out, and then start doing braces. Maybe they'll need surgery to bring the jaw forward in the future. What he starts showing is these pictures of these class 2s that are growing and breathing and learning to swallow differently, having releases of tethered oral tissues, and they're like not they grow into normal conditions. So I have my youngest daughter who this is her, like this is what she looked like. And
Mhm.
so I'm in this situation where I'd been waiting and waiting and waiting, and I'd finally convinced a colleague to put braces on her. And I was like, let's just get going because she's having all these problems breathing. She was, we're a pretty active family. She was cross country skiing, and she was starting to need to use an inhaler. She'd had, if I back up,
Okay.
she had all kinds of little problems from birth. She was more of a struggle to breastfeed. She was way more upset. She had colic. We had like croup with her where, there was a couple times we were like, we need to go to the hospital. We go outside. And as soon as she got in the cold air, her breathing would settle and be like, okay, maybe she's okay. And then, just sort of all these little
Mhm.
things, and her little butt crack was crooked, like when I was oh, that's so cute, like I had no idea that the pelvis
Right.
was did to the way we would
Exactly.
swallow,
Right.
like all this stuff is no. And so yeah, so anyways, fast forward to on one day on Terry Fox Day, she ended up having such a breathing attack. We ended up going to the hospital. They put her on a big cute little puffer with like a teddy bear on it and whatever for kids.
Mhm.
But I was like, oh my gosh, I have a child that's going to need an inhaler now. I wouldn't have imagined. And so
Right.
as she moved through athletics, we kept kind of like, yeah, having
Just
inhalers a
dealing
big
with
deal
it.
for her
Yeah.
and kind of dealing with it and trying. And so um, she became really involved with cross country skiing at a pretty high level. And it was to the point where she couldn't even practice without you needing an inhaler, let alone race. And so she was in these braces, so I talked my colleague 3 months before I went to this course.
Okay.
I talked my colleague into getting braces on. One thing that had happened, which I did not even clue into, was that a little spot became painful for her behind her two top front teeth.
Mm.
And it's common in dentistry to have what we call popcorn emergencies. So somebody has popcorn. Approximately 2 weeks later, when one of those husks that's exactly the shape of a tooth gets underneath, sticks under the gums, gets jammed, and it can be really painful. So I was like, oh, she must have something. It's got to be a popcorn emergency, right? Like it's this
Right.
big thing that was sore and looked like almost necrotic. And I knew nothing about lip ties, tongue ties, tethered oral tissues, restrictions. Like that was all for me the realm of a periodontist.
Mm.
Or some like it wasn't even things that we were talking about. There was nothing we learned about in school. It was just like, so anyway, what had happened, I brought her in the into my clinic. She had these braces on, and I checked for popcorn, couldn't find anything. Went in to freeze it up, thinking it's got to be deeper. Like I couldn't, because it was brown and dying and puffed up, and she was in so much pain because that's a very painful place to freeze.
Yeah.
There's nothing underneath it. So kind of like didn't really know what to do. It went away. I'm at this course learning about the possibility that breathing, tethered oral tissues, class 2 occlusions could actually be managed at an earlier age. And they show these cases growing, and I'm thinking, I've put my daughter in braces, and I just think that perhaps that was a, her papilla, like her midline of her
Mm-hmm.
upper lip. Actually, the teeth were brought together where she had this spacing. The teeth were brought together across
Ah.
this, and it got crushed. The papilla and the frenum was so strong, it actually got crushed and was necrosing and dying.
Wow.
Yeah, so anyway, I I'm starting to think all of these things that I'm learning during this course are things that she's struggled with. The interesting thing was I had the same setup. I had a class 2 occlusion. My like teeth stuck out. I had braces, headgear. I had bedwet till I was 8 years old. I had all kinds of sleep issues, anxiety, sleepwalking, sleep talking.
Oh, wow. You
Um,
had all the signs.
oh, I had it all.
Holy
Yeah,
smokes.
right? My mom actually did some little like hypnosis move with someone when I was about 8,
Mm-hmm.
where they worked with pressure points in my hand to stop me from bedwetting and that to teach me to get up and go to the bathroom at night. Yeah, troubles breathing, all of it, narrow jaw, and I diligently wore my headgear and I so anyways, I just thought it was a genetic inevitability that my daughter was going
Mm-hmm.
to needing braces, and I just wanted them to start as soon as possible because I was starting to hear inklings from other courses about getting started sooner, but I didn't know what that meant by getting started sooner. I thought that was just get started sooner with what we
With
know
braces.
traditional
Yeah.
means braces.
Yeah.
So, um, yeah, so I'm sitting with a colleague from Europe at this course, and on the break, I said to him, I'm like, have you heard anything about this? Like this, like I've just put my daughter, I'm showing him these pictures. I'm like, I just put my daughter into braces, and I'm like, I feel like now she maybe could have grown. And he's looking at me like, and you have a license to practice dentistry? And like, you don't know any of this? Like, what are they teaching you in Canada? And I'm thinking, well, no, like, I
But
didn't
that's
know
the
this.
thing. We have
So,
heard that from some of the biggest names in the world that y'all just weren't taught this, right? So, I
nothing.
mean, everyone is kind of having
Everyone,
these
right?
moments.
Yes.
Yeah.
And then he's like, I have an entire floor in my clinic that's like designated to this kind of work. You should come and visit. So I'm like, okay. So I head over to visit him and figure. And then I just started going, okay. So then also what happened is I was working out of a lab of a totally dear and respected friends and colleagues that wanted to have a dental clinic inside their lab. So we were like, okay, well, maybe between the cancer agency and this, I can be doing something that's helpful for the lab and then have a space to do some clinical work with them.
Hmm.
And then COVID hit. And
Mm.
all the regulations of like, can a non-dental, like how do you work having patients seen in a clinic that isn't owned by a dentist that's owned by, like, so there was some logistical issues that we needed to front, plus the idea of COVID and bring them being very concerned about bringing patients into a lab, and because like all the, people were
Yeah.
at the time like negative pressure and doing all this stuff for air circulation, ventilation, what they did. So it was like we just kind of stopped everything, and I just poured in. I was scheduled to go down to the Breathe Institute in California to meet Dr.
Mm.
Zoggy because
Yeah.
someone had said, well, if your daughter needs a release, you need to train with Dr. Zoggy. So I find him, sign up, and I'm supposed to head down there in April of 2020. So then,
Oh,
they're so incredible,
perfect
right? Of
timing.
course was canceled. And they're such an incredible, uh, them probably
Oh,
like they were,
yeah.
I mean, within 5 weeks, they had a full online course ready to go. And it was like the first Zoom course that I took. So this was mind blowing and incredible. And it was like, it's just such a beautiful place to be putting energy during COVID. And then all these online courses started popping, right? Like a lot of these people that you've interviewed before, like Barry Raphael and people that were on this path and had these mentors near them. And they're like, this is the time for us to get your old slides from the 70s onto Zoom and help you on PowerPoint and make these courses happen because we have time.
Yeah.
So I started
Mm-hmm.
just going really deep into a whole bunch of courses with so I like took online courses with Barry Raphael and studying with Gavin James, who's a big ALF provider. And then I started taking myofunctional courses and from myofunctional therapists who were offering them online. And then more stuff with the Breathe Institute and Myo Masterminds and meeting. And like really, my mentor community became speech language pathologists, dental hygienists who'd become oral myofunctional therapists or myofunctional therapists coming from other realms, but usually from dental hygiene, like osteopaths, craniosacral therapists, and ENTs. And that's really been my mentorship group, aside from dentists doing ALF provision. So I've taken like online and in-person courses from every ALF provider that's out there.
And it's amazing too, because it is such this collaborative kind
Yeah.
of full view that you have taken. I mean, could you
Yeah.
ever have imagined coming out of dental school knowing this is where you would end up? These are the courses you would focus on.
Totally, like totally. And that it was a hard conversation. Like, so then the other thing that happened is I was at the Coyce Center
Mhm.
and it was one of the last courses that I mentored. And Dr. Coyce, John Coyce, the director of the center, came up with this book called Jaws by Sandra Kahn,
Yeah.
right?
It's
And
back here. We
yeah,
love that book.
right. The epidemic under your nose. And
Hmm.
I'm like, oh my gosh, this is so important. And so I got the book, of course, and ordered, whatever you ordered, like 11 copies, because you're like, I need to give this to everybody that I know.
Exactly. Yep.
Right?
We did this. I think everybody does that, right? We did
That's
that with
right. And then you
Breathe.
buy
We did that with the,
the Practice
yes.
Sequence book, Close Your Mouth, right? And Gas.
Yes.
But yeah, like
Hmm.
you just want everybody to read them. Then you realize, okay, I'm probably spending hundreds of dollars a week on books that I want other people to read. And then I'm not sure if they're reading them. So maybe I'll just recommend the books. Slow it down so they
Right.
push a little
You're
bit.
in the grocery store. Here, look, you need to read this book.
Right? You
Yeah.
see the kid with the dark circle and you hold the phone hanging over.
Mhm.
You're like, could I just show you this book that I think you should read?
Right. I always feel
So
so bad because I'm always 50-50. Do I go give you my card and say, please go check out
I
CAP
know,
and
right.
the people we work with? Because I'm not a doctor, but
Yeah,
hey,
I
or do I
know.
just sit there quietly and go, hmm?
Yeah, I
That's
know.
always such a hard choice,
Airports are hard. They're really
right?
so
Hmm.
anyway, what else was
Yeah.
hard is starting into these conversations with colleagues, right? So I
Yeah.
come back, my daughter's in braces. I'm like, I'm not convinced that what she needs is braces now. Like I feel like we need to do some combination of stuff. Like
Hmm.
she needs her breathing. We need to look at her tethered holters and so and reading the Jaws book. And so that was an awkward conversation. And the outcome was
Yeah.
that you know what, I don't think there's really any science to this. And I think we should just take the braces off and you're on your own. And that was like, ooh, right? Because this was like was
It
somebody
was
that
early on. Yeah.
it was early on. It was early on for me. I was looking to him for like us kind of going on this journey together. And he made it really clear that I was on it on my own. And that was hard personally. Again, we're
Sure.
still in a freaking pandemic. You're feeling alone and you're and then it's getting more alone.
Right.
I
Right.
left private practice. So then the other really, really unearthing part of this was that I'm working at the BC Cancer Agency. So the only patients I'm seeing are BC Cancer. So I get all super fired up about my course with Dr. Zagi at the Breathe Institute, right?
Mm-hmm.
And being able to diagnose tongue tie and understanding tongue range of motion ratio, right? The TRMR grading scale that is so clear and so great to use. And in 4 quick
Mm-hmm.
movements, as you know, we can very quickly tell if somebody's got a tongue tie, a functional tongue tie. And so I start thinking, well, you know what? Every Thursday, we're still working at the cancer agency. We've got like every protocol of barriers and we're overwrapped and whatever, like, but I'm still going in and
Sure.
seeing patients because we're keeping the cancer agency running. I thought, well, I'll just start looking at tongue range of motion ratio in these people and, use my mind that way. And yeah, so starting May of 2020, and I've worked every week at BC Cancer since then. And I see on average, like I just work for the morning there, so I see on average maybe 5 or 6 patients. I started testing tongue range of motion ratio, and the statistic is very, very, very high. Like I've done since I can describe to you, I ended up going through wanting to design a study to be helpful, first of all, to integrate. Maybe we can help again with the whole dry mouth, the mouth breathing.
Mm-hmm.
Patrick
Mm-hmm.
McEwen was in with me. We were going to do a lip taping intervention, and I had like another colleague who was on board to do the intervention, the testing. The radiation oncologists were like, no, this isn't a good enough study. And and but what I ended up doing is a database. The statistics are basically over, like it's like 96% of the patients that we see there have grade 4 tongue range of motion ratio. So
Wow.
the patients that we see in the dental department at BC Cancer are of all tumor groups except maybe the torso. So we see the obvious like head and neck radiation group. So anyone with a tumor that's going to receive radiation above the hyoid bone here. We look at anyone who's going to go on to a bisphosphonate medication, which is meant to support stop tumor growth in bone.
Right.
So it
Mm-hmm.
stops bone remodeling and the eating of the bone from tumor groups. So things like prostate, breast, and then multiple myeloma and any of the lymphomas and leukemias, blood dyscrasias that are going to head into stem cell transplants. We need to clear that they have no infections in their mouth or that we don't have concerns about where they're headed. So it's a pretty broad spectrum of patients that we see there.
Yeah.
Not head and neck tumors. And so, yeah, it's this crazy high incidence of.
And are these functional meaning they're going through their everyday lives or are, I mean, what degrees are they as far as, we know that it's impacting their airway or it's restricting.
Yeah, well, it's interesting, right? You start looking at, and so the study that we've done and the data is just coming out now. And again, like Dr. Zagi's trained us well in science and scientific investigation. So in order to eliminate or diminish as much as possible investigator bias to make sure that I'm not just saying that this is what it is, we've got photographs doing the TRMR. And then I have a panoramic x-ray that shows what the setup is of the teeth, the joints, and you can see the nose and the sinuses and the stylohyoid ligaments, which we could get into to talk about, which would be interesting. But these, I've got colleagues who are also affiliates of the Breathe Institute who are now, we've received permission to send the data to them, and they're concurring on the diagnoses of about 20 different findings that I have to make sure that, yeah, we've alleviated the investigator bias. We were going to do 100 patients, but the goal was to say if by 50 the results were so clear that we didn't need to keep going because we know statistical significance happens at 30. Right. But I thought it's a nice number because people can make their own percentages, right?
Sure. And
yeah. So, but it just wasn't even worth it. Like by 50
it was just slam dunk.
It's so clear. Yeah.
And out of curiosity, just because of conversations, we've had like with Dr. Sandra Kahn and others, when you're looking at these panoramics and you're seeing the nose, how many actual triangles are you seeing versus you can tell it's been impacted?
Deviated.
Yeah.
So again, all that data will be coming out and my colleagues will be concurring, but deviation with nasal
Cannot wait.
septum is like, it's very, very, very high. Like we're talking above 80%. The biggest finding is elevation of the lower anterior mandible or the 6 lower anterior teeth.
Okay.
So when we see that the attachment of a tongue tie is to the bottom jaw at the
Mhm.
genial tubercles, pull of that tongue tie, especially ones that when we see this Eiffel Tower, so when you see we can put a photo in right here of a baby even with an Eiffel Tower, I can send you one of those
Okay.
tongue tie, to know that they're going to then grow up and see these pictures, the pull of the tongue tie on the lower anterior mandible. Yeah. So that was actually another uncomfortable conversation I had with the orthodontist, because the encouragement when you start learning from some of these amazing mentors is to say, what's the diagnosis? Like, I get that you've got these clinical signs and symptoms, but we've actually been kind of taught that the signs and symptoms are the diagnosis,
Right. Instead of let's get
right?
to the root.
Instead of what's the diagnosis that's led to these signs and symptoms. So
Right.
we've kind of been taught that a diagnosis is elevated, like is super eruption of the lower 6 front teeth. And like the diagnosis is 100% overbite, where you don't even see the bottom teeth because the top teeth come out 100% over them. But that's not the diagnosis. Like the
Right.
diagnosis is that there's an oral restriction that's pulled. Like the diagnosis is a grade 4 tongue tie.
Right. Right.
That's led to
Everything
the
else is the symptom.
signs and
Hmm.
symptoms of overdeveloped. Yeah. So actually, I'm afraid we have the book here. You know
And that
what?
is just, and that's a change too, right? I mean, in science, anyway, that's in science, it's
Yeah.
always changing and evolving. But now this is just a different way to, I mean, you really have to think about it.
Yeah. So like, I don't know if this is appropriate, so you have to cut this out if you don't want, but like when I first started learning this and was doing these webinars to start building community here of what we were learning,
Mhm.
and I discussed this lower anterior 6 teeth being elevated. Someone sent me a screenshot of this book, Think Like a Monk, and they wrote Think Like a Tongue.
Yeah.
Because if you look, that's exactly what we're talking about.
Oh my
Those
goodness.
bottom front 6 teeth, right?
Yep.
So
Okay. Wow. See,
anyway,
but it's like we were talking about before, and we have said this on other episodes. Once you know it and you
yeah,
know what you're looking for, it's
you
everywhere.
can't unsee it. It's
You
everywhere. It's
can't
everywhere.
unsee it.
Yeah,
Granted, at
so
this
the
point, I
discussion,
mostly look at kids because that's what we do, but
that's what we're doing. Yeah.
I see it in adults.
Hmm.
I go out places with
Yeah.
friends, people that don't know what I do, and we start talking
Yeah.
about it with adults.
Yeah.
And all of a sudden they're like, wait, wait, wait. I,
Yeah.
I snore, I do this, I do this.
Oh
And
yeah.
it's like,
Yeah.
well, do you want me
Yeah.
to tell you? Yeah, go talk to your doctor because,
I
hey,
know.
your chin's kind of retruded. And
Yeah. So I love that you said that, because it brings me to like one of the phrases that I say all the time, which is we're all just grown up babies. We're all just
yeah.
grown up babies. And actually, we had a really exciting meeting in Cleveland this spring. And I know some of the people, Kevin Boyd that you've interviewed, and some of the people
Mm.
that are like in the books, right? Like in Breathe, they're in like they've been in this, and like they are there and they're so passionate about this. And
Yeah,
Brazil is pretty advanced in what they're doing, their
they are.
legislation on tongue
Mm-hmm.
tie assessment. So Mariana Pereira
Mm-hmm.
was giving a presentation in Cleveland, and there were 6 of us that were like right up there, just like,
Mariana is
oh my God,
phenomenal.
isn't
Yeah,
she? Have you
she's
interviewed
amazing.
her?
I actually have interviewed and met her in person. She works very closely with Dr. Boyd. He's on our
Yes,
board. And
totally.
I got the opportunity to meet her because she was speaking at the SEC sleep conference in
Yeah.
Houston in April.
Okay.
And I met her.
Yeah.
She is outstanding. Yeah, she's
It's
outstanding.
amazing. So you would have
Yeah.
seen her research to show that occlusion exists at birth, right?
Yes.
So then
Yes.
when you start to go, right, so if the discussion is that the realm of who's deciding whether or not a tongue tie matters, or a lip
Mm-hmm.
tie, or whatever's creating the dysfunction, even a cheek tie, if the realm is not supposed to be a dentist, because we're not supposed to treat preventively. So say we're not thinking about these elevated lower anterior six teeth, which are going to be an issue later, and the orthodontist is going to be trying to intrude them, which is one of the major struggles of orthodontics, is
Mm,
intruding lower anterior teeth. Well, of course, you're fighting the force that's put them
right.
up in the first place. But say that the defense always maybe from, like, if someone feels that it's the realm of an IBCLC or an SLP, or someone to say, well, it's really, you should only treat if it's going to improve breastfeeding, right? Like, it's all
Mm,
about the baby being able to have proper breastfeeding. But really, what Mariana has shown is that the occlusion already exists at birth. We know that the baby started to suck when they were like 4 weeks in utero, and they're
mm.
swallowing by 12 weeks.
They've
They've
adjusted.
been
Hmm.
doing this for a long time, even when they're born. So
Yeah.
their patterns, their neuromuscular patterns, if that tethering is there and has not had that apoptosis of cells to break it away and become a really functional swallow, we're already seeing malocclusions at birth. And I love the research that she's done to be able to show that. So I've started adding that into our testing, and you can only do it when the
Oh, I
baby's
love
really
that.
at rest and almost asleep. You can't do it once they're awake. Um, but
Makes sense.
you're testing to look and see, and she's got beautiful documentation of the fact
Yeah,
that
she's got a great video of it. Yeah, which I think
yeah,
we've used before. Yeah, and
yeah.
it
So anyway,
which is
that
funny too because and it is just, I guess I'll segue into this because
yeah,
we touched on it, funny enough, in conversations that day after the day that she had spoken at the conference, because
yeah,
it was 3 days,
yeah.
and that New York Times article just will never
Wow.
leave the conversation at this point.
Yeah.
And it was discussed in that article, and it was interesting to hear. I'd love your perspective, but to hear their perspectives on eh, that article was about very different people. Here's what we're doing. Here's why. Here's the research. No, it doesn't always have to be. These are the cases we would say leave it and why, but
Mm-hmm.
here's why you do it.
Mm-hmm.
You know, how do you really combat that? How do you approach that and discuss that with patients when you see it and you're recommending it and they say, "Oh, well, I read this article."
Yeah. Yeah. Well, oh, so is your question, how do I discuss when, like, the criticism of this is like a moneymaker for dentists?
Yeah,
You
yeah.
know what I've started to say?
Hmm.
I've started to say, I was in general dentistry for 20 years, and I had a really full, successful practice that had been closed to new patients for a long time. I made a lot more money doing that than I'll ever make doing this. And if I really wanted to make money, I'd be prepping veneers and putting in implants. It's very lucrative, especially when you're good and it's needed.
Hmm.
And this work is nowhere near the remuneration for the effort, for the daggers you get in your back, for the fights that you have to fight. Like, nobody questions whether an implant is a good idea or not. It's accepted in dentistry, right? It doesn't mean it's going to be done well. It doesn't mean that all of the criteria, like, there's so much to know about implants. It's easy to
Yeah.
not implant well. It's easy to not do veneers well, but they're not criticized as a technique for treating a missing tooth or teeth that look like they could look better or be shaped better.
Hmm.
But
Versus
man,
something that can help
criticized.
your brains, your functions, depression, ADHD,
Everything.
long-term things down the road like dementia.
Which brings me back to your question. We were talking about the study at BC Cancer, and the data
Yeah.
will be coming. But you were asking me if they had other, so if they'd been living well, or if they had other, whatever.
Hmm. Yeah, if it
Yeah.
was
So
quote
you look at
functional.
those medical histories, like reflux medication is a very common finding in not only our society, but in cancer patients. Depression, anxiety, CPAP,
Hmm.
diagnosed or undiagnosed sleep apnea. And then there's the stuff that we're not really recognizing, right? Like when you start to get into, if you know how to ask probing questions with them. But the big thing is, you just take a cotton roll, like a
Hmm.
roll in dentistry,
Yep.
you're maybe aware of this test, but you take, right, 38
Yep.
millimeters. You try
Yep.
and put between their two molars. Like I've never ever seen a cotton roll that fits in one of my cancer patients. It's
And you
100% of the patients have narrow maxillas.
and I
100%.
will thank Dr. Moralia and Dr. Bill Harrell for that. That's the only reason I know of that. That's where I learned it.
It's
Yeah.
beautiful, right? Cheap, free, and diagnostic. So, yeah, so then we know, okay, so the data right now is somewhere between 4 and 12% of tongue tie reported at birth in whatever form, method, whatever the literature is that shows that. And I'm not saying tongue tie causes cancer. What I'm saying is that the people who I am seeing in the dental clinic at BC Cancer have like
The
highest
majority.
grades
Hmm.
of the highest grade of tongue tie, grade 4 tongue tie. And it's interesting to me learning that when there is a fascial restriction and compensations need to happen through life. So say there's a fascial restriction on a cheek, but it doesn't get to soften away by proper function because there's also a fascial restriction on the tongue. So if the tongue tie, the tethered oral tissue of the tongue is tight, you start needing compensations of
Hmm.
using your cheeks to swallow. It's more effortful
Right.
for the tongue. You've got the restrictions that we know are connected in that
Hmm.
deep frontal plane of fascia
All the
all
way down. Yep.
over our toes. So this tension persists through life in function. So then, like, it looks really bad too. Not only is it obviously that's like thick and white and like it's like these are
Hmm.
not just like fresh little ties like we're seeing in these babies. Like they've been through a life of compensation. So yeah, so it's the patients, what I was going to say is that these patients end up, their medical histories are pretty revealing. And I used to play this kind of game with myself where we take this panoramic film that in one dimension lays out a three-dimensional skull in a picture, and I would look at it and I would just kind of like guess things about their health or their history based on looking, at say where on their temporomandibular joints, or if their sinuses were pneumatized, or they lost teeth, or their teeth are worn, like in this x-ray, like guess stuff.
Right.
Now I'm like, yeah, well, too bad about their tongue tie, right? Like everybody's got this elevated lower anterior teeth. And this is interesting too, because going through school and helping, even volunteering at this, like the place where we train certified dental assistants here in Kelowna at our college, like they always have dentists come in and supervise the training, and they're
Okay.
learning. One of the things you teach an assistant is to make it so that the occlusion, like the bite, is straight across, right? So you don't want to have them going up or down, like you want to have it straight. But like I can remember thinking to myself, oh, they're just like, whether it's through practice or whatever, people aren't quite getting it straight. But you know what I actually realize is it's a very common thing to see this elevated lower anterior teeth. You're not going to get a panoramic film to not show what's not there, right?
Mm.
Like we just
Right.
haven't been and so even if those teeth are worn down so that they're almost the same height as the bottom teeth, there's a lot of elevation that's big signal. So that's become a really big sign for me. And I play the game of like, I look at their calcified stylohyoid ligaments, which we know is the connection from, the mastoid down to our sternum in this, and like I don't know if you've interviewed anybody that's talking about the incidence of that, but it's huge. And we're seeing it in kids, right? We're seeing it in little kids on CBCT scans, these calcified. And you know what's the
Mm.
thing? You send off in order to get both a second opinion to be testing your own clinical skills, making sure you're not missing pathology in these 3D
Right.
scans, but also you can get them to report on different findings that you don't want to maybe be spending time figuring out in your own measurements or whatever. They always write back and they say calcified stylohyoid ligaments, which are a non-incidental finding. And I'm like, how could they be
Send,
non-incidental?
send that to
Like,
Bill Harrell. Go ahead. You are not going to get that response from that man.
right? Yeah.
Mm-mm. And
So,
I have to say, because of him and others that I've interviewed,
yeah,
it's been so exciting for me. Because I just got a new dentist because my other one didn't have this and didn't talk about these things.
yeah,
To walk in and they went in to do all of my films, and they walked me in and it's, that's a CBCT, and they're looking at me like,
yeah.
weirdo. Yeah. How do you
How do
know
you know?
that? And I got so excited. I'm like, and are you going to be doing this and this and this thing? And I see, and she's like, yeah, like some kind of a groupie. But all of a sudden, that was the first time I thought,
Yeah,
okay, someone's
yeah,
going to look at all that because I know
yeah.
I have an issue, but someone's going to look at it. And it
Hmm.
changes your perspective. And it changed my dialogue with my provider.
Right.
Never have I walked into a dental provider and had these conversations, but
Yeah, yeah.
it is life changing because you can
Yes.
open the door to these conversations and then you start getting the treatment
Yeah.
and it's night and day.
Which is super interesting because this moves us into the group that I was telling you about, the AIA, the Applied Integration
Yes.
Academy. So this is a beautiful group of a collaboration of two occupational therapists, Mike Cantrell, James Anderson, and Alice Lamb is a dentist. Again,
Hmm.
super highly trained, right? She's been through Pankey and Dawson and Spear and like all these big schools of dentistry. And they teamed up also with neurological optometrist, Heidi Wise. So
Mm.
the four of them are working this group they've called Applied Integration Academy, and their big thing is grounding, compression, and they call their work respiratory neurodontics. And so this has been a pretty cool and again like mind-blowing side of seeing the connection and testing the body and the body's movements and then vision and gait and then seeing how the appliances we work with, ALF and a lower splint and breathing and teaching how to breathe can end up unraveling scoliosis and that you can actually see scoliosis in the tongue, right? And so now it's funny, I had a friend send me a picture on a text one day and I was like, just wrote her like, how are you doing? Kind of, she's like, oh, I'm at the hospital with my daughter. They've done like, I don't know, can't remember how many she said. They can't get blood because they can't get a vein. And she's here because her tonsils were bleeding and we're worried about her. And so I said, can you just send me a picture of like her opening her mouth so I can see back to her tonsils? And she sends me this picture of like all this blood dripping out of all these places where they can't get to get a vein and they're trying to test what's going on. And so now I'm so ruined because not only can I not go to an airport like you're saying and see these kids with the dark eyes and the mouth
Yep.
open, people with the elevated lower anterior teeth when they smile at you and you're like, oh, I feel your suffering.
Hmm.
Like I feel you.
Right. You see the gap and I'm going,
You
oh,
want to just be able
because you
to
know
like
what's caving in.
ask them
Yes.
about their vacation in Hawaii, but really you're like,
And when
yeah,
you get back, could you call your
yeah.
dentist? Right. Yeah.
So anyway, she sends me this picture, and the picture shows a tongue that's pale, and again, I can send you this picture. A tongue that's pale, a uvula that's deviated. The tongue has got a coated dorsal surface. The tonsils are enlarged. And then she sends me the picture of her arm. And I'm like, basically like, well, she has a non-functional swallow. She has scoliosis of her spine. She's got her vagal tone is not matched by looking at her uvula. She's got low iron because her tissues are all really pale.
Oh,
And she's breathing through her mouth because her vessels have such low turgor pressure from having such low CO₂ percentages that they can't get in to get a vessel because they're not pumped up, plump vessels, right? And so she's like, oh my God, how can you see all that? Like, it's frustrating to be able to see all this. But yeah, so
yeah.
um,
And
yeah,
that's I think one of the things that we do hear um from the clinician side over and over and over is this frustration. I mean, okay, first of all, this is the only time I thought I'd ever say this, but kudos for COVID for taking us down
yeah,
because clearly that gave y'all time
yeah, to
to
get this
really
done.
dig in. And I
Yeah,
do think I never thought about it before, but after hearing you talk about it,
yeah,
when you look at the timeline, because I constantly hear in 2017 and 2018, we did blah, blah, blah.
yeah,
So it was just hitting then.
yeah,
And
yeah, totally.
lockdown, everybody had time to study and gather and share. And
Mhm.
I
Yeah,
really think that is why it has launched it into the
I agree.
stratosphere. So
Plus
well
the
done
book
for
breadth,
that.
plus the book breadth. So having
Right.
that published right before COVID, it's like
It was a
that
perfect
made it
storm,
all,
right? For this
that made
all
it
to
really,
just hit the
yeah.
stage
And you know
and
what's one
run.
of my favorite quotes? Do you know
Mm.
Derek Nordstrom? Have you interviewed
Oh,
him?
yes. Oh,
Yeah,
we
okay.
know Derek
So
Nordstrom well.
yeah,
Yeah.
yeah. So he says my like 45 years in this work is for this time in the world right now, right? Like we're at
Yeah.
an epidemic of inflammatory conditions, of, neuro, like loss of neural input, reflexes, speech, like
IQs,
IQs, the ability to
depression's
the
off
bottom of this
charts. Oh my
depression,
gosh.
autism spectrum disorders, ADHD, yeah, like inflammatory mediated diseases, allergies, like
Hmm.
all of these syndromes, right? And he's like, yeah, if we can just get conversion, true conversion, not training, but conversion to a functional swallow, we can get the neurotransmitters on board. We can start to bridge the little gaps, the breaks in development that haven't been there because of whatever reason, and the cost that will show up in our fascia, in our immune systems, in our nervous systems, and in our society, right? So yeah, it's funny. Our staff had a really, like, us coming round to that whole thing where our mission is just providing collaborative care to support the journey of conversion to a functional swallow. That, and knowing that the resilience that we need arises when we develop a functional swallow and we start to develop those neurotransmitters, right? We get the dopamine, we get the serotonin. So the kid that went from thumb sucking to finger chewing to clothing chewing to hair chewing to picking their skin to tattoos to, like, at every cutting, like just looking for dopamine, right?
Yeah.
And that
Yeah.
we find these, and it's just,
And it's
yeah,
all
we're
sitting
in
right
interesting
here.
times.
It's
It's all
right
right
here.
here.
Right. And I think
Yeah.
it, it, it's so, I don't know. I don't want to minimize it because to me it's so easy. I think I've been around Boyd way too long. When you talk about passion, I mean that man
Yeah,
just,
right.
pardon the pun, just eats and breathes this,
Oh,
and
I
it's
know.
infectious.
Yeah.
And so maybe that's why to me it just seems so simple. I've read much and I've talked to so
Yeah.
many people, and it's,
Yeah.
to me it's obvious, right?
Yeah.
Kill the
Yeah.
silo. We're done with the silo. We have
Yeah.
to be
Yeah.
collaborative.
We have to
But
be.
I realize that's simplifying things because just the way everything is set up around the globe and blah blah
Oh,
blah. But
totally. And on every level, set
yes,
up, like
it's
clinics,
it's mm-hmm,
insurance remuneration, understanding, schools of teaching of these silos.
right,
Like it's every level.
right.
Yeah.
And I'm seeing what I think will get us there. What gives me hope is because I'm seeing, I call them little factions. I don't know. I've read too many like Divergent and things like that. But these
Yeah.
little factions all over
Yeah.
of clinicians that y'all are gathering, and you're creating these little
Yeah.
microcosms of sharing and knowledge and collaboration, and like with your CO₂ laborative
Right.
approach.
Isn't that
I
cute?
love that. That is so cute. So,
Yeah.
I mean, I think it my gut says that's how we're going to, one of the
Yeah.
ways, right? Because it's going to take several
Only
cogs to move
way.
this, but how do you foster that and grow that in this kind of environment?
I got to tell you, it's challenging.
Yeah.
And, I also feel a certain amount of, I don't know, like maybe guilty passion in terms of that, because I
How
also
so?
like have, when we talk about, say, my continued journey through this, I realized that I couldn't just work at the cancer agency. In fact, I was feeling very depressed about what had used to be kind of my, like, it was like, I'm gonna love this. I love going to the cancer agency. You know what I loved about it? I love that patients feel like I'm on their team because I'm in the hospital. I'm in the public
Hmm.
healthcare system. I'm not that dentist that's just out there being greedy and making money by having a private clinic and having a
Right.
business.
And I have to
Like,
come see you every six
yeah,
months.
and I
Right.
hate you, and I don't want to pay you for what I already hate anyway. Like, yeah, it's like I'm on their team, and I had a lot of knowledge and I could be empathetic, but I could just be there for them and then help
Mm-hmm.
them. And then most of what they needed there was free as well. So like it's like this good feeling, right?
Yeah.
It went from that and leaving private practice to going, all I can see now is tongue ties. Every single one of these patients has the 20 check marks of long-term compensations in the body from a non-functional swallow and tongue tie. They are in a system that is funding all this care. And like we're still treating end stage disease, even if we think we're getting it early, because we really needed, they had this when they were a baby,
I was
right?
going to say, right, we're still treating the
They are
symptoms
just
instead
a
of
grown-up
backing it
baby.
up.
Yeah.
Yep.
So I started going like, oh my God, what have I done? Now I have no
Mm-hmm.
ability to make an impact. Now I'm basically treating end stage disease when I've learned that what I need to do is treat babies. I couldn't bring babies into that lab that I was working with. And then we're trying to figure out how to even see people. And it's not the place for breastfeeding moms. Plus, I'm trying to figure out how
Right.
to do all that work. So then I start renting a clinic from another colleague. And then I ended up committing to creating another clinic of my own. So I went from like having simplified everything to making everything way more complicated, getting pretty like sad about what I was seeing in my cancer patients and what I felt my ability was to do to now help them, trying to design this study that I thought was going to be helpful and getting all these awesome people on board to do it. Like we said, Patrick McEwen and these colleagues and
Mm-hmm.
and Dr. Zaghi. And it was like, and then it became that it was not going to be possible to do this study at our agency. And then like letting kind of those people down and the time they put in and the effort and the kindness. And then being like, oh my gosh, okay, now I really have to do this. And I have to do this kind of for the fact that I like let down this whole group, but it was very hard. And then to go and like keep myself learning and growing in this, and then taking mentorship in baby release courses from all these good people around, and then
Mm-hmm.
figure it out yourself and what ones need to be done, what ones not need to be done. What are they saying about mandibular tendon in, Marina Rakabato's courses? What are we learning about who should we be doing mandibular tendon in babies? Is it reactive? Is it compensatory? Is that a place to treat? Do we do lower lip? I mean, upper lip and tongue are already controversial. What about buckles? What
Right.
are we talking about
Right.
that when we have an osteopath and a craniosacral therapist come in and hold? And then what's that feeling like in our community? And then I have a release provider not too far from me who'd had some like discomfort with the medical system on his own and was like on his own path to figure out where he's willing to let this all in. Meanwhile, you're super highly criticized by everybody that's doing everything. You're just trying to
Mm-hmm.
learn to do a good job with it, and you really care, right? Like you
Right.
really
Right.
care. And you're trying to do this all through a pandemic and like and
Mm-hmm.
build a clinic and then everything. So
It's a lot. It is a
it
lot.
was a
But you know what?
lot.
I don't
And
think that research you've let anybody down, from my opinion, because for me,
yeah.
again, this is an outsider, but for me, I'm that kind of person that's going to see that and grab it and gobble it up and go, there you go. There's another example of, if we fix it now,
Yeah.
this is what we're avoiding. So,
Totally. And I guess what I
right.
mean is I let like the initial study that we worked for like a year to build, where we were going to do an intervention, where we were going to teach cancer
Okay.
patients to mouth tape and
Yeah.
do and actually be doing a metric on improvement of symptoms of xerostomia, dry mouth, and maybe even mucositis based on having a drier mouth. And it was an intervention, and having it be an intervention made it a more complicated study. So what I mean by letting those
Yeah.
people down is that people put a lot of time, a lot of energy. Patrick McEwen even made videos for our cancer patients to describe how to breathe, how to mouth tape. Like it was very, that was very sad. So that's why I feel like we
Yeah.
got, I have to keep this going.
Yeah. That makes
But
sense.
what I wanted to say is that when we talk about um, like the silos and bringing people together, what
Mm-hmm.
I do feel like is I feel like where I'm at now is like, again, Derek Nordstrom said, like we're on the cutting edge of not cutting by using photobiomodulation at an advanced level with like optogenetics and neuro reprogramming with the Orlays and baby lays that we use with the 1064 laser,
Yeah,
right?
let's talk a little bit about that because
Yeah, so we should talk about this because
we haven't dug into that at all on this program.
no. So let's talk about this. And what I wanted to say is that I feel like I do not want to be critical of a single colleague of mine that is not using this technology. That is not my intention. But what I do feel like is my passion, my seeing, my connecting the dots, and my wanting to sincerely help may have had me do more aggressive clinical releases than I would do now. For sure it had. For sure it
Okay.
had. And so I may have not, like, I may have given anyone who had an argument to say, oh, they're too, whatever. Like, maybe there was a case where I was, right? So where I'm at now, this many years into having done releases, I'm using two modalities.
Okay.
So I always do non-surgical releases first with baby lays or oral lays. So this technology, it's again Dr. Nordstrom, who's
Mm-hmm.
been the spearhead of this amazing techniques. And
Yeah.
so there's a laser that has a 1064 wavelength, and the beauty of this wavelength, it's a collimated laser. It's able to penetrate without creating heat at the surface, but it has four impacts. You basically you can feel it. It feels kind of like sunlight on your skin. You follow a very
Mm-hmm.
specific protocol that reaches 6 of the 12 cranial nerves. So there is a neurological reset that happens with this.
Okay.
You have we test reflexes beforehand. So in an
Okay.
infant, for example, we're looking to see if their eyes can track straight ahead and make eye contact with us. We're watching for signs of like divergent or convergent eyes. And as soon as we see that in a baby, we'll say to the parent, do you sometimes notice that the eye wavers? Yeah, but they said that's no problem, or they'll grow out of it or whatever. But what we know is that there's neurological input to the eyes, right? The optic nerve. And so we can affect that with this protocol. We test palmar grasp to make sure if you put your finger in the baby's palm that their fingers close over your hand. We test lateralization of the tongue. So we put our finger over here and over here, and the tongue should follow it.
Okay.
We do what's called a heart-shaped touch. So I make like a heart like this on the
Mm-hmm.
baby's face, and it should have them. I want you to then put your finger in their mouth and start sucking. So it should elicit a suck reflex.
Okay.
And then we also test for startle reflex. So you're holding the baby and you should be able to go like, and just drop it and it'll go, right, and put its hands out. So those are all reflexes that would be normal intact reflexes that we want for a baby. Baby lays or oral lays, or use of this 1064 laser as a non-surgical release modality, goes into the tissues and it has an impact cellularly. So it gets right into the mitochondria of our cells. So like if we were to go science back to like high school science, even like the
Mm-hmm.
Krebs cycle and
Yeah.
ATP, right? So like a flower or a plant gathers sunlight and it gives it the energy it needs to grow. This 1064 wavelength that Dr. Nordstrom has worked with goes right into our cells and into our mitochondria, and it's delivering the form of energy to our cells. So repair, inflammation, growth. It's like another gap that's been missed is filled. So we
Mm.
talk about that, right? Like starting at 4 weeks is that suck, swallowing by 12 weeks, all through in utero, and now the baby's born. Whatever gaps haven't been met, whatever's not happening in those reflexes, we can start to bring them on board by getting into the cells with energy and ATP. So it's beautiful. It's like really it's like a human becoming a plant. It works in the fascia. So our fascia, as you would know, is collagen, this
Mm-hmm.
magical, beautiful web of interconnectedness that's got all these different planes of fascia throughout the body. It's made of collagen web and there's liquid inside it of hyaluronic acid. So the hyaluronic acid becomes thickened or gelatinous through trauma. So trauma of compensations, trauma of medication involvements, of injury, of whether it's physical, emotional, like the childbirth, of needing to have
Mhm.
interventions in order to have childbirth happen, all of those start to impact the fluidity of the hyaluronic acid in our fascia. And so
Mm.
fascia can get stuck. So fascia, we know it only stretches 3%, right? You can't stretch fascia, but you can make it glide by making the liquid that may have gotten sticky or gelatinous or even starting to become crystalline,
Mhm.
by liquefying it and making it make the fascia glide. So
Okay.
we can put images. I'll have like a before
Yeah.
and after
Okay.
showing what the tethered oral tissue looks like before using the non-surgical release modality of this 1064 laser, and then what it looks like immediately afterwards. And the coolest thing is we make sure that the baby is totally online in their
Okay.
midline, neurologically firing. So their palmar grasp is then equal. Their eyes are like looking straight at you. Their swallow goes from being like thrusty or chompy or uncoordinated. We can actually have it become the tongue, like we don't even move ahead with our surgeries now unless the tongue is suctioned to the roof of the mouth and they have a functional swallow, which we can test with a certain, then the Nini soother the pacifier that we like to use, you can see right in the
Mm.
mouth. You can see that they're swallowing. So now we know we've done the neurological, the fascial like softening.
Mhm.
The muscles get information as well, like neuromuscular sensory, like it's like a control alt delete for the system. It goes, okay, everything's all just needs like a bit of a reset, boom, and then here it is. And now we only want to promote this balanced functional midline, the relaxation, the calm. Like that's what the parents always say is like, I've never seen my baby so calm. We have videos of like babies starting out crying and upset with us, and then we
Mhm.
do this protocol and they are so calm. So they move into releases with their nervous system relaxed. We know they've achieved a functional swallow. Their tongue is suctioned to the roof of their mouth. They can now produce their own serotonin. Their own dopamine is going to be there from this swallow. And then we do this really conservative release. And it's become totally amazing. We use it in kids, adults, everybody. Like it can soften and relax in addition to that. And here's the other thing though, right? It's like none
Mm.
of this work is like a magic pill, right?
Right.
So there's a series of home care like exercises and runs
Myofunctional
yeah,
support.
that you need to
Yeah.
do, of course, and then additional ones to go with this 1064 laser, but that there's then afterwards, of course, the myofunctional support, craniosacral therapy, osteopathy that has to be used to let the benefit move through the whole body. But now we've actually got the tip of the iceberg, right? But the metaphor is
Mhm.
always it's going to the rest of the body. But we've given the message to the fascia that it can glide. We've made the release more conservative. The body's midline has gotten all this messaging to center neurologically and to be able to just let the body receive the releases in a balanced state, and the stretching is easier in a baby or in an
Mhm.
adult for because the
For
tissues are soft.
anyone. Right.
So you
Yeah.
might see a baby like that has this habit that they are swallowing with their upper lip, right, and their
Mhm.
cheek. They've got the downturned corners of the mouth, the U-shaped upper lip, whatever. The jaw is far back, and they're struggling to try to make this suck swallow work. We've
Mhm.
actually seen the jaw like come and pop forward because the tongue is now free enough to come forward, come up. The baby's sitting there relaxed. The parents are like, we've never seen our baby so relaxed. And look at their jaw is forward. And then the mom puts them on to feed. It's a different
And they
experience.
latch.
They latch, they can open, they often say,
Mm.
look how wide they can open. And so it's become a real thrill and a joy for us to be doing these really conservative releases and getting parents to understand, like, so if the tip of the tongue is actually the tip of this whole digestive tract,
Mhm.
peristalsis, which we know is the movement of the smooth muscle of our digestive tract from the top all the way down to pooping out, that it starts from the tongue tip, right? So it's the wave
Mm-hmm.
that starts, just like the wave in a stadium, right? Like if someone starts the wave and it really flows and moves through, it's like a good feeling instead of when it gets
Sure.
dry, it's like,
Right.
oh, didn't go anywhere.
Right.
That either needs to be started again, or that's where we see the things you've heard many of your colleagues then speak about, like a head bob,
Mm-hmm.
right? Somebody does that. And I have a video
When
of
they're
a
trying to
little
swallow. Yeah.
baby because they've got to start that peristalsis some way if they can't do it from the tip of the tongue. So if the tongue is thrusting, and we see this all the time, right? Babies come in, they've had reflux, like problems spitting up. They come in and they're on omeprazole or they're put on like, reflux medications. It's not getting better. They've been on them for 4 to 6 weeks. They're looking at upping the dosage. And then we recognize a non-functional swallow. We bring them immediately online with a functional swallow by using this 1064 laser technique. And then they actually have peristalsis happening. So then the craziest thing is the parents who come in and say, our baby used to poo every 10 days or every 7 days. And the day leading up to the poo, they were screaming, their body was tight, they were in so much pain.
Mm.
Now their baby's pooing like I keep meaning to do a post on poop. I think that would be the greatest thing to be able to say, you know
This
what,
is
like
how it should be. Mm-hmm.
this is how it should be. And peristalsis that's happening because of functional swallow, the relaxation of the fascia, the melting of this hyaluronic acid into a liquid form from the gelatinous or the sticky form, letting that fascia move, letting the diaphragm go, like all this stuff is happening, and the baby has the release. They're not that
And
upset
that's all
when
it
the parent
was.
doing stretches. Like when the parent needs to stretch the upper lip and the tongue and get in there, and that's like super hard. The tissues are soft now. They move. The
Yeah.
tongue isn't like this fighting organ that now is free, but it has to be like held back. It's so much different, and it's still hard for the
Oh,
parent.
sure.
But like as a clinician, I used to for our recalls, so we do releases. If so, now our protocol is we don't even let anybody come. Like we've sent a refer, and of course, like the New York Times article. Now I'm saying, okay, now we need to do baby lays, and there's a fee associated with it. Oh, now what a cash grab! That dentist not only wanted to make money off these releases and all these babies that don't need it. Now they want to add this baby lays thing, and now they're really money hungry. And it's like if you knew what it takes for us to add this into our protocol, to have staff trained up to do it, to buy the laser, to do it's like they have no idea what they're going
Yeah.
to say.
Yeah.
But anyway, that aside, what we now do is we really like we don't even have people come here who aren't aware that we do dual modality releases because it's been enough months in our community. We started in like October. So we went through like having all our referrals drop off and people go like, okay, that's a final straw. This clinician is just greedy and making money and like what's this baby lays thing and people can't afford it and da da da. But once you do it, you can't do it another way, right? You go like, I
Yeah.
want to see these babies succeed. So I used to, so we do our assessment. We would sometimes, but not always, do release the same day. Sometimes people would just come for assessment, go home and think about it. Sometimes they would want to do release the same day, but we always insist, and usually they're referred by lactation consultants, speech language pathologists, myofunctional therapists, or like osteocranios who are working with babies, right? So that's how they
Okay.
even came to us. So we don't even work with people who aren't on that side of the collaboration care of the silos
Mm.
down. But then now we've started to recognize that we can get quite an impact on changing out having any compensation of the cheek or lip tension by doing a 1064 like non-surgical release, having the baby use a ninny pacifier, which you can only hold on to if you
Okay.
have a proper functional swallow. Are you familiar with the ninny? Have you heard
I
about that?
am. Mm-hmm.
So like you can't, there is no stock and ball to that. You can't grip lips around and
Yeah.
hold and then retrude a jaw, right? You can only hold a ninny if you have flanging and the ability to properly suck. And so we could have a whole long soother conversation. I'd be happy to do that. But the message is we now see like almost no reattachment. Like it's rare. I used to, so they would come for their
No.
assessment. Maybe we treat the same day, or they come back and treat. Then we do a 1 week recall and a 2 week recall, and then if needed, a 2 month recall. And or they, it could be virtual further out or whatever. But I used to stand outside the room, and my assistants would say, our breastfeeding educator, okay, I'm ready for you for, I've got a 1 week recall. Here's that. I'm like, okay, please let there be no reattachment. Please let there be no, just like praying before I walked in the room.
But now that's
It's such
not.
a joy. I go in there
Yeah.
like, this is what's better. This is what's better. This is what's better. Here's what we're working on. The baby's responding this way in their reflexes. We've done this little Q-tip test to get the neuromuscular integration of the tongue. Milk tongue's gone away. That's the
Mm.
biggest thing, right? I keep
Yeah.
saying, when is somebody's release successful? It's successful if they do not drool, if they don't have reflux, and if they can have their tongue suctioned up to the roof of their mouth, right? Then we actually know.
Mm.
And if not, then there's indication for using this non-surgical continued release technique on the neuromuscular side of things, because it's getting into the nerves and reprogramming, getting into the brain and going
Hmm.
back to the brain stem. Here's these nerve efferents sending back and saying, let's go back and do what we're really supposed to do now that we have these freedom of these tissues. So sometimes they just need repeated visits and training to break those old habits that started 12 weeks in utero, right? So
Right, right. Which makes, and it's interesting too, because in school, and I know it was the same in med school, but the brain, the brain, the brain, the brain, the brain, right? That's the
yeah,
power that does everything.
yeah, yeah, yeah.
Well,
The tongue.
apparently it has a friend and it's the
Yeah.
brain in the mouth. And, who knew the mouth had this much power,
Yeah,
especially starting at birth, that could impact what your life is going to be like in 60, 70 years.
totally, totally. When we see babies do their first breast crawl in our clinic because they were
Hmm.
unable to do a breast crawl for whatever reason, maybe it ended up being in a C-section and the mom was unable to tolerate the baby on their tummy at the time. Maybe the tethering was so tight or their mouth was too small or they like things weren't whatever wasn't allowing, they couldn't get a flange, they weren't coordinated enough to do the breast crawl or it wasn't offered to them or whatever, um, to see them do. So what we'll now do is we really promote like laid back feeding to have upright baby swallow happening, not necessarily on their side. Like there's
Hmm.
places for that, and we don't like tell people that what they're doing is wrong. We just try to offer, and I'll say often, like if you were to have something to drink right now, would you like to lie down on your side to swallow, or would you like to be upright? And so
Valid.
if we're
Yeah.
training a symmetrical functional swallow, and what we're asking is the tongue as a midline structure to
Hmm.
go up and be symmetrical, do we want to be as upright as possible? And so we look at the Japanese studies, right, which show that
Hmm.
really the best way to do it and that a baby's capable of doing that. So once their reflexes are on board, babies who come into the clinic who sometimes have like head bobbing or they can't put their head up right or their eyes
Hmm.
seeing whatever, after we've used our non-surgical 1064 release technique and we offer them the breast crawl and we support the parent in being able to just put their hands at the baby's feet and maybe have the arm there and we watch that baby bobbing and rooting. Ah, that's the other reflex we tested, the root reflex. I forgot to say that, but and they're like, this is they couldn't have done this. Like their cervical spine has become strong because we've treated, the with the laser, we've done the cervical spine and all this stuff is on
That
board.
works way back.
The
Yeah.
baby and the mom, the release the mom feels when they're laying back, they're relaxed, their shoulders are open, they're not, turned forward. They're laid back. The baby has done this breast crawl. They come up and they're looking at them eye to eye. And then the oxytocin comes in, right? Then
Hmm.
this is what feeding is about. And so they are feeling this baby on the breast and they're looking at each other. The suck is coordinated. They're not chomping, they're not resisting, they're not pulling off and pushing off. They're actually, I always say to the parents, like this moment right here where they've struggled for this first feed and then you're there. It's like that's when they are like having to make decisions as a teenager. This is in them now. right? Like this right here, this moment
Yeah.
where they struggled and fed, and then the oxytocin came. That's the reward, like right there, right? Like that's your first bits of serotonin
Mm-hmm.
and dopamine, they're happening. So, whether and so there we even just this morning, I had a mom in who struggled through two different NICUs in our province, and she's been in the care of so many awesome, well-intended, highly trained
It just didn't
people
know. Mm-hmm.
that did not see this tongue tie. She
Yeah.
tried for 2.5 months and couldn't. So now the baby's 6 months old. She's now been to a pediatrician in our town who said, yeah, no, I don't think that's a tongue tie, is a problem. I could show you we'll put up the picture of this one. And so now, what's really sad? This baby has no tongue use. Like he comes in, he's literally pouring drool. The
Mm.
mom's shirt is wet. His clothes are wet. He can't swallow. He has no functional swallow, but not only that, he's got complete cranial asymmetry. He's got a right torticollis that has not been even diagnosed yet, treated. She had not been in the hands of any physical therapist until she finally was told by a friend, maybe she goes. So it's a really weird gap in these siloed systems,
Mm-hmm.
not
For right
seen
now,
as
yeah.
important. And this is where my goal is to be really seen and known as someone who's discerning, conservative, but I'm not gonna not do the care of the non-surgical part of the release to bring the baby online first. So we did get a lot of the baby's reflexes online, but we didn't properly. We got a bit of the swallow happening, and is an improvement, but he has like he has no tongue use. So breastfeeding ended up failing for them, and this has been about 3 months now. So he's bottle fed. But he's not soothed by putting a finger in the mouth. He doesn't
Mm-hmm.
react. There's no signal. And like I really hope that this gap for him that we can get to with these conservative modalities, the release, we ended up doing a release because he really needed, there's no way he couldn't have a release. It's like one of the tightest ties that I've seen. But yeah, it just really brings back the importance of us recognizing the brain part, just
Yep.
like you said, and that the
It's all,
brain and the
yeah, it's
tongue
all
are
connected.
all connected. Yeah, and so, I think about I just think that I'm so grateful to have that on board, and I'm really, really being more drawn to wanting to be there for babies. I'm so
That's
keen,
where
and
it all
my
starts,
says, right,
right?
like in his
It
practice,
starts
9 years
there.
old is a senior citizen, or is it
I
which?
love that, right? The geriatric.
The other thing I love that Kevin said
Mm,
in the spring at a conference I was at, he was speaking for a speaker after lunch, and they're ringing the bell and they're giving people the warning, they're trying to crawl
mm.
people back into, then everyone's so like whatever. He gets on the mic and he says, look, you've all come a long way to hear me speak, and I've come a long way to speak, and we've got a limited amount of time, and I've got stuff I want to say. Let's get going. It's awesome. It was basically like,
Sounds about
no,
right.
like, get in here. I got something to say. Talk
That
about
sounds
past.
about right. And anytime you hear him speak, he's only going to touch on this much because he knows this
So,
much. And
yeah,
yeah, and we've got for parents that haven't heard him, if you go to our YouTube channel, we've got playlists set up and we have
yes,
tons. Everybody that we've been speaking about is on there. Nordstrom's on
yes,
there.
yeah,
Mariana's on there. Kevin's on
yeah,
there.
yeah,
Bill Harrell. I mean, a
yeah.
lot of people are on there.
All these
And we
good people.
even have a video from the Breathe Institute, which is Zagi
Yeah,
and Couples,
yeah, yeah,
that he's doing this exact laser.
yeah,
And granted, this is a grown man, but still, it's cool because you can
totally.
see it and he tells you what it feels like. So you're
Yeah,
going to know what your baby's going to feel. So
totally.
we'll put your video with that so that parents can kind of have
Great.
just another balanced perspective so that
Yeah.
you go in informed.
Yeah. And you know what's really cool about, I mean, not only Dr. Zagi and Dr. Koppelson, but the whole Breathe Institute group is how committed they are to being able to continue learning. And if their protocols are shifting, yep, yep, we're doing it different now. And that's the way I
Yep.
feel too, right? Like, I feel like, you know, it's really important to me for people to understand that we've added in this modality and it's non-negotiable for my care, and that we're so committed to becoming really a place where people go, like, I want people to go, somebody's having a baby. Let's get a group of people together and see if we shouldn't get a gift certificate for them to have an assessment and treatment of gender
Right.
issues, right? Like, they don't actually need
You've got enough
Levi's
bibs, my
overalls and
friend.
all the little,
Yes.
yeah. And in fact, you don't even need a bib if your baby has a functional swallow, right? So yeah,
Excellent point.
yeah, and so I really feel like that's my motivation, is to be seen as like just so open and willing and ready, but ready to recognize that it's not negotiable to get the nervous system online before we do conservative releases, and the releases become more conservative the more the nervous system's online. So it's one of
Right.
those
And the more we're learning, and then
yeah,
we're gonna be
totally.
more collaborative. And I want to
Exactly.
see this as part of
Totally.
these
Yeah.
Lamaze and in like
I,
prenatal classes. That should all be in there. And then it's
yeah,
gonna be added to the
totally.
curriculum of all the medical schools,
Yeah,
not just one, all of them, dentistry,
totally.
pediatrics,
Totally. Totally.
everyone.
It's just part of it.
And
And
then
you
we
know
can
what?
see this change.
Yeah, what I was going to say is another real hats off to Dr. Sagi and Dr. Koppelson is when I went to the AIA in Houston in October, the Applied Integration Academy, and they had this course on body and bite, and learning about when the body needs surgery and when the body needs breathing, like respiratory neurodontics, right? When it needs
Mm-hmm.
breathing, the brain and the tongue on board first, then the body and the spine are aligned. We've gotten rid of these scoliotic curves, and now we can do expansions or surgical, all the amazing care that Dr. Koppelson can do. So he and I were actually partnered up for some of the, like the tests we were doing on C-spine and these shoulder internal rotations. And what it brings me back to is when we were talking about CBCT and how you were very
Yeah.
excited that your clinic has CBCT. So I took a CBCT of a staff member the other day, and kind of like the whole airport thing, kind of like the like going to a coffee shop or whatever and seeing people and you're like, I don't really want to, I just gotta look aside. This staff member of mine was one day we were leaving the office. I said, oh, what are you up to tonight? She said, oh, actually I've got a physio appointment. She said, my shoulder's really sore. Like I've started dragon boating and now my shoulder's really sore. I'm like, do you want me to look inside your mouth? And look, yet she was kind of a newer staff member, so we hadn't done. So she's like, I said, do you want to see if I can help you? So we do this test that you learn at AIA, which Dr. Koppelson also knows, and this amazing group has taught us, where you have the shoulder at 90 degrees and the arm at
Mm-hmm.
90 degrees, and then you bend the arm down to see, and you're holding here so that you're not, you see everybody
Okay.
has got the posture that's compensatory.
Right.
You've
Right.
got the
Got you.
shoulders back and you're
Mm-hmm.
holding the shoulder like that, and you do this test. What
Okay.
point does the arm stop? Like there's a point that stops without this being able to rotate.
Okay.
So when you get to that point,
Mm-hmm.
then you go inside the mouth, and if there's a limitation on one side or the other, so you know what the
Okay. So
limitation.
right before it rotates is where you
Yeah,
stop.
right before
Okay.
this starts to lift up off the table or
Okay.
this starts to rotate, yeah,
Yep.
can you get to
Yep.
90 degrees in this, right?
Mm-hmm.
So so then you go inside the mouth and you feel to the second molars.
Okay.
As a dentist, it's super annoying when somebody has flared second molars and they need a rubber dam clamp on there because they need decay treated, and you're trying to get your burr in there and it's all like to the cheek and they're trying to get them to move their jaw over and whatever. Now I know that if the second molar is flared, we're actually talking about palatal bone connected to the middle bone of the skull, the sphenoid, which is the direction of everything in the skull, right?
What?
So we're touching and impacting the gorgeous butterfly shaped bone that connects to all the 22 cranial bones by touching the back of the second molar, like of the jaw. So if you go in and you feel that one of them is more flared than the other, you're starting to recognize that there's like a cranial strain or some type of rotation in the cranial bones that connects to um, the development of the arch on that side. So I test her shoulder internal rotation. Of course, it's completely limited. She's
Mm-hmm.
sore. She can hardly move the shoulder. And we go in the mouth. Sure enough, that molar is flared. I'm like, okay, just stay open, don't bite down or use your tongue after I do this, but you just go in and you just do 20 little pulses to that area, like really, really
Okay.
gentle, osteopathic, like just physiologic movement pulses, like the pulse of the brain, the pulse of the tongue, just
Mm-hmm.
what the body is ready for physiologically, right? You push on that and then you have them stay open. So there's no more input coming from any other nerves. And you do the same test and the arm like falls to 90 degrees. She's like, I'm like, I know, have a good physio visit. Like, and then you know that this highly trained, maybe even not totally siloed physio, maybe already has some type of interconnection, but who would think that I could lightly pulse
Mm-mm.
the second molar, affect the internal rotation of the shoulder, which is happening because it's connecting to the sphenoid, which is all getting connected like into
Yeah.
both the nervous system and the physicality of how we move our bodies. It's the craziest party trick dog and pony
This
show.
is part of why I love my job because I have yet to
Heard
read
that
one
one.
of the books that has been given to us that we need to read for something or do one of these podcasts
Yeah.
where I don't learn something and my mind is blown. It's kind of like when Linda came on and she was talking about fibromyalgia
Yes.
and she was diagnosed and
This
you
is
know and
Linda
then
Palladino or Linda?
Harris. And
What book is
so
that? Can you lift it up higher? Linda
oh yep, there you go. It's on our reading list.
Linda Harris. Okay. I don't know that book.
Oh
Oh,
my gosh. Okay. So get it.
okay.
It is a fast
Okay.
read and
Okay.
it will blow your mind because she went in with fibromyalgia and jaw issues and all of these things.
Yeah.
And her dentist is like, oh, I bet it's your 13th tooth. And she's like, what are you talking about? Sure enough, you know, we do the films and everything.
Yeah.
She's got like a cap or something, or
Yeah. Yeah.
we address it, and guess what actually goes away? It's just mind blowing to me that
Oh,
we
I
have
read
all
that.
of
I
this.
have read that on your website. Yes. 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 Yes.
It's
Yeah.
mind blowing,
Yeah.
absolutely mind blowing. And to think that we're getting this knowledge, it's still so early, and I understand that, right? But
Yeah.
and it's actually, let me rephrase that. Actually, not that early. Thank you, Dr.
Yeah.
Boyd, because there are so
Yeah.
many papers and things he has brought that this has been
Yes.
out here for like 80
Yeah.
to 100 years.
Yeah.
But
Yeah.
in our consciousness, modern,
Yeah.
mainstream, this is still early.
Yeah.
And
Yeah.
that we could affect these changes to where people don't have fibromyalgia
I know.
at birth,
Yeah. I know.
or just monitor and let's work on their dental up until
And
the age of
that,
6. And you have a totally different
right?
human race out here walking around.
And that's where it's so cool. I'm gonna close the, okay, I'll make sure we come back to the whole notion of Kevin bringing that up, like Marina's work and like the legitimacy of a dentist being on board at birth. A
Mhm.
malocclusion exists at
As
birth.
part
Functional,
of the birth
it's
team.
part of the team,
Yes.
right? Okay, so
Yes.
I want to come back to that idea. But what I wanted to say about the shoulder internal rotation and the CBCT is we're heading down as a staff to actually, we've cultivated 3 days of private mentorship with Dr. Nordstrom in July.
Wow.
So we're taking his brain and heart and mind all to ourselves for 3 days. And as part of
Mm.
this, I want to have all my staff worked up for their own care so that when we're down there, I'm seeing him deliver their appliances. I'm watching him look and observe them. And we've done our part here. And I've done my like preparation and he's got the case assessments and the CBCTs and the scans and the whatever. Like everything's already there. We're actually just like starting to start their path of the journey of like ALF therapy basically. And
Okay.
so anyway, so I'm taking her CBCT the other day because she's going to
Amazing.
meet with the people. And I sit down to view it and I've got it in as 3D and I can show you a screenshot of this. We'll put up a screenshot. Remind me to give
Okay.
you this one. I'm looking at her 3D scan and I can see her upper right first molar is flared in the x-ray. And I'm like, oh, as soon as I look at that, I'm like, oh my gosh, she's totally gonna have trouble with her right shoulder internal rotation. And then I'm like, oh my gosh, she did. We already did that test a couple months ago.
That's
And
crazy.
yeah, and the crazy part is what AIA has done for me and then had me realize, which also makes you feel like, oh my gosh, now I even have more responsibility, is now you look at them and you see that you get them to open, you see the tongue elevated one way or the other, whether it's TRMR, you haven't even looked at that yet. You're just looking at their uvula, which is deviated. You see that their vagal tone is going to be off. That's the other thing that happens with using this 1064 in this format of oralase, is that the uvula straightens out. So you know that, you know, the connection to C1, C2. So we're both getting vagal tone online.
Mm.
Trigeminal nerve as the gatekeeper of the vagus is starting to become safe. The body's becoming safer. The uvula straightens out. There's not that compensatory pull. And then you see, and you're able to see like the cervical spine start to align. It can be harder than that in an adult, but we still see a lot of this happening.
Okay.
But we need more modalities on board to do it, work with it, handle it. But
Right. Because they've been dealing with it for so long,
because
the
they've been
damage has
dealing with,
been
so there's
done.
more
Yeah.
compensations in the spinal, you know, and they walk, they stand, they've got
Yeah, that
shoes that
train
are
left
worn
the
in
station.
there that are all
Hmm.
like, right? Like there's so many parts to it. But now I look at people's tongue and I already know that they're probably developing a left bunion. And when you say that, and they're like, yeah, I have a bunion on my left toe. It's like, I know, I'm really sorry about that. I'm sorry that I'm able to see that, because it's kind of unfortunate. But what's really not easy is managing. So this comes back to the whole collaboration thing, right?
Hmm.
We need to all get out of our silos. We need to be able to work together. But like, we're highly trained, caring, empathetic people who have our own businesses, our business models, the way our softwares are planned, the way our staff is trained, what our
Hmm.
education is, the CE that we've just enrolled in that's taught us something that doesn't have this information in it. And then like someone goes to get orthotics and they're like, yeah, my dentist knew that I had a bunion on my left toe because of my second molar. And they'd be like, okay, they're a quack, right? Like, so it in sometimes you can't premeditate where this information is going and how
Hmm.
it's going to be received. And what's unfortunate for me is I've had physical therapists say, get out of my realm. Like,
Yeah.
the dentist, you have no right to tell my patients how to posture their shoulders. I'm the physio. I'm the one who's going to tell them how they hold their sternum, not you. And that's hard, because it's
Yeah.
kind of like the orthodontist who is like, I'm not on this journey with you. The braces are coming off. Then it's like the physio who might be sharing coaching duties with me in the cross country ski team. And I'm saying to them, you know what? I'm really concerned about all these little kids and all this mouth breathing that we're forcing them through, and how cold the air is. And like, I really would like, you know, in our bunny rabbit program for us to start by like training mouth breathing. And if we can't do that, maybe we need it. But that is an uncomfortable place,
Oh, sure.
right? And like, these people are good at what they do. They've been
Hmm.
highly trained and they're successful. And maybe even too, they're like kind of moving into the easier stage of their career. Like I was moving into the cancer agency, right? I was just
Right.
going to take it easy. I was just going to be on their
But
team,
that's
making
where we
cancer
are right
patients,
now
right?
with this big medical change, right? It's here. We're at this precipice. And
Here.
and I apologize, but I know I'm because I'm supposed to be, fairly neutral, but I'm very passionate about this because
Yes.
it takes these
Yeah.
luminaries and
Yeah.
people like that have been on the podcast and people like you
Yes.
and
Yeah.
that are open
Yeah.
to make this change. Somebody has to stand up and start to make the shift
Yeah.
for it to trickle down, right? For it to
And
take
it's
effect. And it's also going to take the
uncomfortable.
parents, these airway mama bears,
Yes.
to stand up and go,
Yeah.
no, my
Yeah.
child's not going to grow out of it. I
Yeah.
respect you. You worked
Exactly.
really hard in med school. You're great, but I'm going to go to
Yeah.
someone else.
Yeah.
And these are hard
And
choices on both sides.
totally hard choices. And it's totally hard choices because the risk is you never know where this information is going and how it's going to be presented and where it's going to land. And my one of my biggest struggles has been trying to keep on top of like the letters, the communication about this, the documentation to be, because they're like, what, and then like being able to, so like I have a couple colleagues who are physical therapists, osteocranial, like in fact we are so blessed here. There's rarely a week goes by where I don't have a visiting osteo, cranio, physio
Wow.
that comes in to be holding either the feet, the diaphragms, the head, like working cranial osteopathically with me. And I've done my own training in it, so I can hold and I can feel and I know when things are aligned and people are
You're very
feeling.
blessed because those are not easy to find here.
They are not easy to find. They're like, we have so many. I've
I have
actually,
been
you know what?
looking. They
I
are
should
so hard to
create.
find in the US.
Yeah, I was speaking with a colleague from Portland after ICAP in Cleveland, and they were like, I have none of this going on here where I am. And I said, where I live, it's a really nice place. Plus, the dollar exchange is very advantageous for someone from the US. And
Hmm.
like, it's a fraction of what I know people are paying in the States. You should, like, I should create like a destination model where people come, they get their baby assessed, they come to our beautiful region. We have collaboration with hotels. Our physical therapists are here ready for them. They can have their cranio, their osteo, their lactation consultancy. Like, we can be like a destination because it's all happening here in this town. It's so awesome.
I'd sign
And
up for that. I sign up for these solo tours around the world. I'd
yeah,
kill for something like that because it
right?
really is when you're out here in the
Yeah,
trenches. And I'm sure it's like this in other
yeah,
countries because we've talked to other people, but
yeah,
in the US,
yeah,
both for adults and for kids, to find this,
yeah.
it's not easy. And that's one of the biggest things we're advocating on is how do we get this care
Yeah,
to
how do we
these
build this?
kids?
Yeah. And so
Yeah.
I'm thinking, okay, so maybe we become like a destination for this integrative care for places that are underserviced right now. We're easy to
Medical
get to,
Disney.
whatever,
I
right?
love it.
Yeah, yeah. So, and yeah, and they can enjoy themselves while they're here. There's lots of great things they can do and be part of. So anyway, that got us diverging off of something, but it's good to set it. But what were we just talking about before that? We were
But there we're
talking
talking about the collaborations between.
collaborations, yes, and
Mhm.
how frustrating it is for me when I hear that somebody's misunderstood or um, like taken offense to the possibility that the mouth is connected to the body and that yeah, so it's coming, but then it also is a huge learning path on my path. Just because I know the information, I can see it and diagnose it, doesn't mean I'm an expert at treating it. So I still need to get
Yeah.
mentorship in all this treatment and how to integrate that, and then to be able to bring people in and have like they need to earn their money too, right? So then, am I bringing them in and I'm paying them to be part of this? Am I training them? Do I know enough for retraining? Does
Right.
my
It's
staff
all
and
such
then the
uncharted
staff,
waters,
right? Like
right?
the staff are like, oh my God. One of my staff said, you just have to really flow with Hilary because you never know when the next week she's going to have like gone, oh, okay, now what's really important to me is I'm recognizing these cases that don't have an anterior coupling reflex, and I need to add acrylic to all these appliances to get a little bit of contact in the front teeth first here before we get, it's going to signal the
But you're
serotonin,
developing, you're learning.
signal the
That's the whole
premaxilla.
thing. That's why the Breed
Totally.
Institute is
It's
constantly, and,
hard.
and Airway Health
Oh,
Solutions, they're
so
updating
good.
their curricula
Yeah,
all the time
all the
as we
time.
learn, right?
As we learn. So yeah, so then
It's
just figuring
amazing.
out what we can do and handle and what have you is good. But yeah. So was there something else that we were going to go back to? We went back to the CBCT, and that was so cool to be able
Yeah.
to see and go like, oh, I already know what her body looks like by looking at her second molar and being able to, scroll around. I know what's happening in her body and her spine. And sure enough, then you look and you can see C1 is off on occiput. Occiput's over to the larger lung. You get her to look and you can see, yep, sure enough, this side. So we need to train breathing and compression into this in order to straighten out the spine, because the larger rib is
Hmm.
the raised shoulder and the cranial strain is pulled down to there. What is that? This is the 6-month-old baby that had torticollis, who was in my clinic with no treatment of torticollis, no functional tongue, and of course they're elevated like this. They're
Hmm.
totally scoliotic, but we can. And then today he comes in, he's like upright, and he still's not using his tongue, but he's more upright. So,
It's
and
just
yeah, like
amazing. And it's never too late. And that's the other thing. Granted, we're focused on kids because we
yeah,
understand this is the
yeah.
root. Let's get to the
Mhm.
root,
Yeah.
fix before six. We're not going to have these problems. But some of us
Yeah.
have already left that gate a
Yes.
long time ago.
Yeah.
So it's never too late. So even as a parent, if
Mhm.
you're listening to this and you're
Yes.
thinking, I have this, I have this, I have it, and you're hearing yourself and what we're describing,
Yeah.
it's not too late.
It's not too late. You know what's one of the best things you were mentioning? So Linda, the book that she's got there, and
Mhm.
what have you, like we've been in a sense of overwhelm in our clinic just by the demand and the ability to explain and be ready for systems to handle all this care. And as a result, well, what are we supposed to do in the meanwhile? And so we work with this free app called Human Garage. Have you ever heard of them?
I have not.
Okay, they're all about fascia. So again,
Okay.
it happened during COVID. This guy had this idea that if you kept working fascia, you could release a lot of body problems. And they literally worked out of their garage so that they were in open air space. And they moved to Canada, and they've got this beautiful like message to be able to reach like 1 billion people in however amount of time. But it's to just give people free access to how to open up fascia. So Human Growth
Hmm.
is a really good app that we recommend for
Okay.
people. And then of course,
Definitely
like
check that out.
you do too, probably recommend like Patrick McEwen's Buteyko, like adult
Yes, the
kids.
breathing.
I love that,
Absolutely, we
right?
do.
Yeah.
Yeah.
Just try to give them anything they can that's free and available right away. And yeah, we
And I can recommend that app also for kids because they do some
mhm.
things on there for kids. But
Education
I
program.
use it. I absolutely
Yeah.
love that app.
But you're totally right that it's not too late. One of like a couple of the most reward. So one of the other honors and privileges, which I kind of feel like, am I really the person to be doing this? But John Coyce has asked me to speak at this Coyce Symposium this summer, and so when we circle back to like the what brought me to this was him, Jaws, the integrative oral medicine course at the Coyce Center, realizing this path, and then uh, finding that the mentors that I needed for this
Mhm.
were in all these other domains, right? It's been a
Yeah.
long time since I've been at a dental conference. And actually, there was like one time I was going down for a hands on ALF course in Issaquah, and I texted John and I was like, "Are you around? I could come and say hi." And he wasn't home. Other than that, I haven't seen him for like 6 years because I've been putting all
Mm.
my money, all my resources, all my energy, all my knowledge, except for we have a small Airway study club group through the Coy Center who I really treasure and value. Actually, you've interviewed Steve Acker, I think.
Yeah.
Yeah. So so we have this beautiful group that has totally kept me fueled and going. And but anyway, John, Dr. Hoyce wrote to me this fall and he said, hey, would you consider coming to talk about all this, like, or come and talk at symposium? And I said, sure, what do you want me to talk about? And he said, this cranial manipulation stuff you're doing. So what's kind of cool is I accepted that honor, and I still feel like there's about 40,000 people in this world who'd be better to do it than me, but I'm going to just do my very best to do my best for that. But really what it's come down to is I'm preparing cases where I see a baby who has the
Mhm.
same physiology, the cranial side bends, the elevated shoulder, the breathing difficulties, and the occlusion. And then you can see the same anatomical setup in a kid, kind of the way Marina does with the actual kid growing up. I'm just doing like
Yeah.
sample of this one, sample of this
Like
one,
a snapshot.
and
Yeah.
then getting to the adult age. And so when you talk about to these parents, yeah, it is not too late. My cases are ending with showing adults where they had shoulder discrepancy, eyes that were
Mm.
asymmetrical, midlines that were off, non-functional swallows, depression, difficulty sleeping, migraines, body pain, bunions, knee aches, like all the whole thing. And now they're sleeping, they're breathing, their jaws have developed, their midface has developed. We know that if their midface has developed, their sphenoid is involved, that beautiful butterfly bone, which again we could talk
Hmm.
about. I'd love to speak more about that. But when the cranium, as Derek Nordstrom would teach us, and AIA, Mike Cantrell and James Anderson and Alice would be teaching us, as we're seeing going from a flattened skull with a flat midface, as we develop the midface and allow the occiput and this area of the skull to develop, when that's happening and we're creating space for the tongue, whether the restriction was this way or this way,
Hmm.
as that's developing and the tongue is starting to have a home and we're getting the serotonin release and the dopamine release, and they're going through the releases that are happening in their fascia through the osteopathic collaboration that we insist upon, or we won't work with, like our care is insists upon that because we know it's needed. If they've had releases in our care, including the non-surgical and the surgical releases, but as their fascia is unwinding, their digestive systems are unwinding, their nervous systems are relaxing, they're sleeping, they're dreaming, they're not waking up to pee. their mouths are closed, their like breath is there, and their faces are developing these mid faces that are allowing us to see the corner of the angle of the mandible that didn't need
Mm,
surgery to be brought forward, but it was always there. It just couldn't come forward because it was trapped behind this maxilla unless it developed into a class 3 and jumped it, right? But if we can
right.
get that upper jaw forward, which Marina shows in
Yes. Yeah.
her
Yeah.
piece, but if we can just see the body unravel and start to develop, these cheekbones.
Mm,
We see those glare, one of those tests that we know, right, in kids or in adults, is if we see a lot of whites of the eyes when we're looking at somebody, these cheekbones are underdeveloped and back. When they come forward and then the whites of the eyes go away and the dark circles under the eyes and the cheeks come forward and the jaw's widening, and then you start to see this corner of the angle of the mandible and it's not melting into the neck. You're like, yeah, this is a 47-year-old baby, right?
yeah. Right.
Yeah.
Because we're going back to the root,
Yeah.
going
So
all the way back to the root. And for anyone that doesn't know, because we've mentioned it a few times, and we've talked about it on other episodes, but if this is your first episode,
mhm,
this whole cranial facial thing, you're thinking,
yeah.
what language are they talking?
Yeah.
I'll include the link to Dr. Stephen Hall's episode. Um, he's phenomenal, and he's got a great book, and he explains it so beautifully. And yeah, that was my introduction to it, and it can be a life changing
It's huge.
addition to your medical journey.
We learn that the cranium fuses at age 21, right? We learn
Right?
that.
Yeah.
There's this beautiful video of this pediatric dentist, or sorry, pediatrician who's actually teaching us about the suck and swallow. That's so good. And in it, as an aside, she mentions this is what the bones look like before they fuse, but they don't fuse. They're always free moving. They're always, I mean, our occiput fuses and our
Always
mandible,
impacted.
but they're all movable. And so this beautiful bone, the sphenoid, which is a butterfly shaped bone that has two long wings that go up and two that go down, connects to every single bone in the skull. And we have
Mm,
access to that through the maxilla. And whatever the sphenoid is doing, the upper midline is doing. So as dentists, for us to see a midline that's off, we can expect then. It's not that the teeth genetically came into the wrong position. The sphenoid is actually in some type of cranial imbalance.
mm,
And the metaphor that I use, I was taught by the physical therapist who works, one of them that works with me, who's a craniosacral therapist. She's been a physio for like 40 years and craniosacral therapy for over 30 years. And she's not a certified osteopath, but she's done so many of the courses in osteopathy. It's really a pleasure to work with her for all the skills she can bring in. She described to me craniosacral therapy. So if we were to talk to people who haven't known what it is
mhm,
yet, like cranial strains are when the bones of the cranium are jammed in certain ways or misoriented. So the sutures of our skull have different ways that they join. Some of them join like a zipper.
mhm,
Some of them join more straight. Others are like plate tectonics and they slide
mhm,
over each other. In particular, the temporal bone, which the ear and the ear canal, and is the home for the little bed, the glenoid fossa that our two jaws
mhm,
live in. It's a movable bone. So in dentistry, we have this pursuit of the ideal occlusion, the bite between the top and bottom jaw. We have this pursuit of it being something that can become stable and is like, we want to give the person this grounding sense and we look for it dentally. And there's so many highly skilled, highly trained, super, super well intended people looking to build these bites that may not know that the bone that the jaw joint lives in is movable. And
mm,
it's movable because it's connected to the sternocleidomastoid. So it's movable with muscular strain, it's movable with impact strain, and it's movable based on the way that our tongue has helped the sphenoid bone to have its movement or been at the, they're chicken and egg. but this bone is what we balance out when we
Mm.
do ALF therapy and other forms of dental appliances that I'm sure you've got lots of people that have been on that have talked about how the impact of cranial balance. And for me,
Mhm.
it's using like our ALF principles with Derek Nordstrom, but the bones are not fused, and so they can get jammed in these sutures. And the way, one of my other mentors, Herman Ramirez, he's a pediatric orthodontist in Ontario. He goes through and he says, what are some of the sutures in the head when he's testing you? So he wants to know, the parietal suture, he wants the lambda, he wants the maxillary suture, he wants you to tell. But he ends up saying the suture between the maxilla and the mandible
Mhm.
is occlusion. So the way we
Mm.
bite is actually the suture between these two jaws, which brings us back to this cool painting,
Yep,
right?
it does.
The
Yeah.
suture. So I made a t-shirt for him that has the original picture before the premolars put in, and then a second one, and it says the suture between the maxilla and the mandible is the occlusion. And so
Mhm.
we as a profession in dentistry are studying and training and working are very, very hardest and most heartfelt to establish a stable occlusion for a patient to feel good. If there's a cranial strain that exists when we establish that occlusion, if their shoulder's still elevated, if they have a scoliotic tongue, if they have a strain in those cranial bones that are sliding like plate tectonics or that have jammed in a certain way, and we build a solid occlusion, we're actually can be serving to reinforce the cranial strain. So when I was telling you about my staff member with the dragon boat
Mhm.
shoulder and the internal rotation and me touching her second molar, I didn't have her bite together after I did that osteopathic move, because if I did, her occlusion would
Undo
immediately
it.
be the suture between her maxilla and mandible. It would undo the benefit of her shoulder and internal rotation, which is exactly what we did 2 seconds afterwards for me to say, now just bite together. And then, we can't move her arm again, right? So
Mm.
the way that this Glenda is the name of the physio who explained cranio to me, explained it is to say, when you go to a drawer and you go to pull out a drawer and it's something stuck,
Right.
and it's like, okay, so I have three choices. One is I didn't need it that badly. I'm just going to close the drawer. Right?
Right. Right.
Someone else can figure this out, right? Like,
Mhm.
or like legitimately, I'm in a hurry, or I don't think I have the skills to do it, or there is somebody else who's better at this than I am. I'm going to wait for them, right?
Right.
Legitimately, we're going to walk away.
Right.
The other choice is we can take that drawer and we can go
And
like,
just yank the fire out of it. Yeah.
and like maybe that thing will spring out. It's like, oh, it was the staple remover, or it was those barbecue tongs that had opened because they didn't get slimmed up to the dishwasher or whatever. Like whatever it
Yeah.
was that was causing that, maybe they broke on the way out. Maybe it chipped a little bit of the drawer. Nobody will notice because it's like on the undersurface. Maybe,
Mhm. It's still
you know,
workable though.
it's still workable. We got it with force.
Mhm.
And you know what? I can buy a new wooden spoon, or I can get a new tong or whatever, right? But I got it there.
Yeah.
The other option is to just take the drawer and jiggle it a little bit, push it in and jiggle it and look in, right? And go like,
Mhm. Yeah,
oh,
because you
maybe
reach up under there and you push
yeah,
down whatever it
yeah,
is.
maybe I
Yep.
just need something else here. I'm gonna take this and I'm just gonna like push it down. Okay, yeah.
Mhm.
So maybe there's your ALF. Maybe there's your um Invisalign expander. Maybe there's your like whatever else you're using, right? Like, okay, so I've got I'm gonna and then okay, now I'm just gonna like I'm gonna push it in just a little further, and now look at that, and get it all
Mhm.
the way out, right?
Yeah.
Ah, and here it is. It's intact, and I'll take better care of it now, right? So
Right.
that is craniosacral therapy or osteopathy. You assess and you find something that's stuck. You understand what it's connected to. You know if it's going to need further support other than just manual therapy, whether it's releases, whether it's whatever, right?
Right.
And but you move in the direction of the lesion and you actually use this biotensegrity, right? Gavin James would teach so clearly with Barry Raphael on biotensegrity.
Mm-hmm.
You take the tensegrity of the fascia of the body, the muscles, the compensations, the tensions, the hard parts, the soft parts, the drawer, the cupboard, the walls, you've got the legs, you've got the feet, your gait, you've got your lungs, you've got this whole body of hard, soft parts, rhythm centers, all interconnected with this web of fascia. And you just move in the direction of the lesion.
Mm-hmm.
And then it starts to let go. And then you can gently, within the physiologic range of the body, start to have it release and breathe and open, and the parts themselves are functioning more ideally and they're available to you. And that is what we do.
Life changing.
Craniosacral therapy and osteopathy. Yeah.
It's life changing. It is absolutely life changing. So
Yeah.
at the end of every episode, I always hand it back to you, the guest, because y'all are the experts.
Yeah.
And so for the final word, the final thought for our parents, I will turn it over to you.
It's never too late. It's never too late. And if your gut feels like there's something that's being missed, you're probably right. And you need to trust your gut as a parent. And it's really important when you start to see and recognize these things that you have to remember to see the beauty as well as the diagnoses and the struggles. Because it's so easy to just start to look at the airport or at Costco or wherever you are and just see all these cranial strains and shoulders and tongues and breathing and whatever. It's easy to get, like, I have parents who like email every week and they're like, when will she see us? Because we know that there's
Yeah.
and it's so easy to get really like fixated on it that it can almost drive you crazy. And this is where Dr. Sherry Sammy, who's, I don't know if you've interviewed her, she has taught me to say, remember to make sure you see the beauty in all of these ages and life forms and in yourself first before you start in on diagnosing on what you really see, because the humanity of what the world needs right now, where we're seeing the breakdown of all of our geopolitical, financial, mental, all these other systems, everything's breaking down. The only thing that we can grow is our systems of humanity. And yeah, so it's really important to not get too wrapped up in, it's this balance. You need a balance of being able to listen to your gut, know that you may have to look a little bit further and wider for providers, but it's growing and it's coming. And to be very gentle on yourself and on the people that you see these diagnoses in, because you really have to see the beauty in them first and the humanity and the spirit. But on top of that, be very gentle on the people who are still in the silos, because we want to bring them along with as empathetic of care as we possibly can. And the more that we're gentle on the people who are being the visionaries and the putting their backs out there for all the lashings and the stabbings and whatever we're getting professionally, be gentle on them, because it's very hard and we're just humans too.
Right. Agreed.
Until we were 8 and had 2 rounds of orthodontics and right?
Agreed.
So
agreed. And you know who else says? Dr. Claire Stagg says that also, and she says grace. It's all about grace. As a mom, give yourself grace. You didn't know. As a provider who's just coming into this, give yourself grace. You didn't know. And it's
Totally.
somebody that's still in the silo.
Yeah.
Give yourself grace. I mean, we'll get there, but it's going to take everyone.
Can you just excuse me 1 second? Mom, I'm in the middle of a podcast. Can you turn that off, please? Sorry, my mom just arrived. You may need to just clip that last bit out. Do you mind
I
saying that
absolutely.
about Grace with her again?
Yeah,
Yeah.
that it's Dr. Claire Stagg says it so beautifully as well, and it's all about giving grace. As a mom, give yourself grace. We didn't know we were doing the best we could. As a
Yeah.
provider, you work so hard through medical school, dental school, whatever.
Yeah. Yeah.
Give yourself grace. You're
Yeah.
doing
Yeah.
from your heart what you
Yeah.
were taught, right? You
Yes.
didn't know. And
No.
anybody that's in the silo,
Yeah.
give
They're
them
still,
grace,
yes, give them grace. Yeah.
because that's
Yeah.
how we're all going to get there together.
Yeah. And the only thing we can do is meet people where they're at.
Yep.
So, I have moms with babies who are like, is it too late? And they're like 3 months old. I'm like, oh
Oh,
no, oh
you're
no.
fine. You're great. Yeah.
We treat 65-year-old babies like you are fine. Give yourself grace. Don't get, when you start to learn this information, don't get so fixated
Don't
that it
panic.
drives you crazy, because
Hmm.
I've been there. I've totally been there.
We've all
And
been there.
yeah,
I'm
it's really,
hosting this show, and I am that 53
yeah,
year old baby that has the outcome. And I'm looking at my two younger babies, 20 and
yeah,
below, going,
yeah,
I'm so sorry, but I didn't know. So I've been
yeah,
on that same journey. So I am speaking from the heart
yeah,
as one mom to another. Take a deep breath.
totally, totally. And be so gentle. And then accept too when there's boundaries that clinicians have, had to draw, because they can only handle so much too, right?
They're human.
They're just human, and we're all just doing our best. And
Yep.
yeah, that would be my biggest message. And then I think really spend time with like the most ancestral parts of human need, like touch one another and,
Hmm.
and like hold
There's
skin.
something to it, right? There's something to that.
Yeah, just like spend time with running water and be in the forest and just like let the nervous system settle, because it's, even if we treat these babies' nervous systems and we get them on board and we release these tongue ties and they have a functional swallow, we may have reached that goal of growing resilience, which is the whole goal of the combining modalities, right? This growing resilience in human form to help heal our world can still catch up with us when we get stuck with screens at nighttime
And the
and
technology. Yeah.
technology and poor bedtime. So much of this information is available to us on podcasts and technology, but like really, 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 really start to respect your screen time and darkness and running water and trees and forests and skin time and quiet and
And you
music
need it.
and all of that. Like those things will help your young one while you find your care providers. Yeah, more than you can imagine. And be a beacon for breaking down the possibility that anybody in this field is looking to make money off of it, because it's not that lucrative. We're
No.
doing it because we care.
And we're back to grace again. So show them grace. Right?
Show them grace. People are doing this because we care.
They are. I
Yeah.
cannot thank you enough. I mean, I know this was, and for parents listening, I mean, this was a big keeping podcast, and I cannot thank you for just, I could talk to you for hours because there's just so much, but
Let's keep going.
you've shared so much, and you've just been so transparent, and I appreciate you taking the time to come on here. Thank you so much, Hilary.
Well, I really appreciate being asked, and I'm really grateful to have had your time. And I'm happy we can do an episode 2.
It may
But
happen. So don't put that out there for me because I will take it because I have so many questions and I know our parents are going to send us questions.
yeah, we
Thank
didn't
you.
even get into neonatal health and how that works.
No,
We got lots of things to cover. So
there
yeah.
are. So stay tuned. There'll probably be another one. Okay.
I'm so grateful to meet you, Rebecca, and so grateful for the work you're doing and for CAF and for all your board members and all those good people and those good names that
Mm,
are just like just these humans going
thank
through
you.
this
Yeah, they're
crazy.
pretty amazing, aren't they?
Yeah, yeah. Thanks so much.